Set your sights on intramuscular injections. In this presentation, various aspects of the intramuscular injection will be discussed. The intramuscular, or IM, injection is the first of 3 injections you will learn in this lab course. Medicines administered by injection into the body tissues or by infusion into the circulatory system are classified as parenteral medications. IV injections and infusions will be introduced in the fall semester of the junior year. Parenteral medications are more quickly absorbed than non-parenteral medications. In addition, invasive techniques are required for administration. Remember, the more invasive a procedure is, the greater the risk for injury to the patient. The dermis, the subcutaneous tissue, and the muscle are the 3 body tissues into which an injection can be given. Each type of injection requires a certain skill set, as well as a needle of the appropriate length to ensure the medication reaches the desired tissue. It is up to the nurse to select the right needle. Note the layers of tissue on this slide. The dermis is the second layer of skin under the epidermis. The subcutaneous tissue is the loose connective tissue beneath the dermis. This layer houses the adipose tissue. Therefore, the thickness of the subcutaneous layer varies considerably from one person to the next. The muscle is the deepest layer of tissue. Muscle tissue is more vascular than subcutaneous tissue. Therefore, an IM injection is absorbed more quickly than a subcutaneous injection. Consider this. If the nurse selects a subcutaneous needle that is too long for a particular patient, a sub-Q injection could easily go through the subcutaneous layer and into the muscle. Likewise, if an intramuscular needle is selected that is too short, it could very well deposit medication intended for the muscle into the subcutaneous tissue. Failure to inject a medication properly could result in serious complications such as improper absorption of the medication, nerve injury, localized bleeding, tissue necrosis, and sterile abscess. Now let's take a look at the supplies required to prepare and administer an injection, beginning with the syringe. A syringe consists of a barrel, a tightly fitted plunger, and the tip. The tip may be luer lock or non-luer lock. A luer lock simply implies there are threads at the syringe tip that allow a needle to be securely twisted into place. A non-luer lock does not have this feature, and needles are simply pushed firmly onto the top of the syringe. A measurement scale is a very important feature of the syringe and can be found along the barrel. The units of measurement are used to prepare the desired injection amount. Syringes are most commonly marked with scales in tenths of a milliliter, but not always. Some are marked by 0.2 of a milliliter. A small TB syringe is marked by hundredths of a milliliter. Insulin syringes are marked in units. Some are marked 1 unit at a time and some 2 units at a time. Careful study of the syringe scale before beginning preparation is a must. The nurse must determine the measurement each line represents to ensure the correct amount is being measured. This is a critical element and essential to patient safety. When preparing an injection, the nurse lines up the top ring on the plunger's rubber stopper with the desired marking. Syringes range in size from 0.3 milliliters to 60 milliliters. When choosing a syringe, always select the size closest to the injection amount to improve accuracy of preparation. With IM injections, it is uncommon to use a syringe greater than 3 milliliters. However, on rare occasions, a 5 milliliter syringe may be required. 5 milliliters is the maximum volume that can be injected into a large, well-developed muscle. Injections are invasive. As a result, strict sterile technique must be upheld when preparing and administering injections to prevent infection. Contamination can occur in several ways. In regards to the syringe, keep these principles in mind. In the package, the syringe is sterile. The sterile integrity of the following parts of the syringe must be maintained to prevent contamination of the medication: the interior of the barrel where the medication will be, the plunger length, and the tip of the syringe where the needle is attached. Remember the fundamental principles of sterile technique. Sterility is maintained by not allowing a sterile item to touch a non-sterile surface, such as the nurse's hands, the counter, etc. The nurse manipulates the syringe using a careful no-touch technique in an effort to uphold the sterility of the parts noted on this slide. All of these areas come in direct contact with the medicine. Bear in mind that an item is either sterile or not sterile. There is no state of almost sterile. If the syringe or the needle becomes contaminated, discard it and start over. In addition, please note, sterility cannot be restored by wiping a contaminated item with an alcohol pad. Now let's take a look at the needle. The needle consists of three parts: the hub, the shaft, and the bevel. The hub is the color-coded part of the needle that attaches to the syringe tip. The shaft is the length of the needle, and the bevel is the slanted tip. Note the illustration of the bevel in the lower right corner of the slide. The bevel creates a narrow slit in the tissue when injected that closes more quickly and neatly after the needle is removed. The nurse always positions the bevel up when giving an injection. If you're unsure which way is up, relate the bevel to a spoon. In the same way a spoon faces upward when in use, the bevel is up when the needle is injected into the tissues. Needles have two features: length and gauge. In regards to length, needles vary from 3/8 to 3 inches. The nurse chooses the needle length based on, number 1, the injection route. Does the injection need to go into the muscle, the subcutaneous tissue, or the dermis? Secondly, the nurse must also consider the site within a particular route. For example, an intramuscular injection can be given in the upper arm, the leg, or the hip. The size of the muscle mass will impact the needle choice. Lastly, the patient's size and weight is a big factor to consider. The nurse must evaluate the amount of subcutaneous fat over the injection site. Understandably, longer needles are required for IM injections and shorter needles for subcutaneous injections. The needle gauge is expressed as a number and describes the diameter of the needle. The smaller the number, the larger the diameter. The larger the number, the smaller the diameter. Yes, it is counterintuitive. The gauge of the needle is selected based on the viscosity of the medication. A thicker, oil-based medication will require a larger diameter needle, such as an 18 to 21 gauge, and an aqueous solution requires a smaller diameter needle, such as a 20 to a 25 gauge. Evidence-based practice guides the length and gauge needle the nurse selects when administering an injection. The nurse chooses within the recommendations for each injection type. To prevent introducing infection, the needle must remain sterile. Remember, the needle has three parts: the hub, the shaft, and the bevel, and each of these must remain sterile. The bottom line is the needle is handled by the nurse by the protective outside cap only. Needle stick injuries are a serious safety hazard associated with injections that can expose the nurse to blood-borne diseases such as HIV and hepatitis. Prevention is key. Avoid using needles when effective needleless systems or safety needles are available. A safety needle is one that is engineered to prevent needle stick injury, such as needles with a protective sheath or a plastic guard attached. It is not practical to supply these types of sharps in the nursing resource lab, so please discuss the use of safety needles with your clinical instructor in the hospital setting before you use them. Never recap a needle after medication administration. The needle is contaminated with the patient's blood and body fluids after use. Use a one-handed scoop method to recap needles when absolutely necessary. Never use two hands to recap a needle. Plan for disposal of needles before beginning of procedure by locating the sharps container in the room. Never hand contaminated needles to another healthcare worker for disposal, and likewise, never accept contaminated needles for disposal. Each member of the healthcare team, from phlebotomist to doctor, is responsible for disposing of his or her own used needles and sharps. If a needle stick injury does occur, immediately milk and wash the wound with soap and copious amounts of water. Report the needle stick injury and initiate the procedure for follow-up care promptly. Injectable medications are supplied in vials, ampules, and pre-filled syringes. One critical element that relates to injectable medications is that the solution must be suitable for the desired route. This information is noted in writing on the medication label. You will see for IM use, for IV use, for subcutaneous use. Instruction on each of these, the vial, ampule, and pre-filled syringe, will take place in each session. IM injection fast facts. Muscle is richly supplied with blood, so absorption will take place quickly. Needle length for IM injection is determined by patient's body mass index and the site selection. Please refer to the table you've been provided on Blackboard for details related to each injection type. This table will need to be memorized for your skill check and for bedside practice. Remember that needle gauge is determined by the viscosity of the medication. IM injections are always given at a 90-degree angle perpendicular to the body. The Z-Track method is a specialized injection technique that prevents the medication from leaking from the muscle up into the subcutaneous tissue, and it is recommended for IM injections. There will be more on Z-Track later in this presentation. If a patient's muscle mass is small, an alternative bunch method can be used. The nurse grabs the body of the muscle between the thumb and the forefingers. Lastly, you may be wondering about the different versions of Michelangelo's David at the top of this slide. On the left is the David as it was sculpted by Michelangelo, and on the right is a much heavier exaggeration. Contemplate your needle choice for the one body type versus the other. The amount of subcutaneous fat that overlies the muscle will be a big consideration in choosing a needle long enough to reach the muscle. To aspirate or not to aspirate with IM injection? That is the question. Let's first define what aspiration is. Aspiration is a precautionary step used with IM injection to detect if the needle has entered a blood vessel. After the needle pierces the skin, the nurse steadies the syringe barrel and pulls back on the plunger for 5 to 10 seconds. If the needle accidentally entered a blood vessel, blood will appear in the syringe. In this case, the needle is promptly removed from the tissue, discarded, and a new injection is prepared. If given, the medication would be given intravenously instead of intramuscularly. The necessity and effectiveness of aspiration in recognizing vessel penetration is currently under debate. Here is what we know so far. Aspiration is not required with subcutaneous and intradermal injections. Aspiration is not indicated with intramuscular vaccines, so if you give a flu shot, you do not have to aspirate. In the Nursing Resource Lab, aspiration is still required for all other IM injections until more conclusive evidence becomes available. In the clinical area, defer to the agency policy on aspiration and have a dialogue with your instructor about how he or she wants. There are 3 intramuscular sites from which to choose when giving an IM injection. When locating intramuscular sites, the nurse uses underlying bony landmarks to zero in on the body of the muscle. IM site number 1 is the deltoid. The deltoid is a smaller muscle on the lateral surface of the upper arm. This is an appropriate site for small medication volumes less than 2 milliliters. The injection site is located 1 to 2 inches below the acromion process. Locating each IM site will be demonstrated in detail in each lab session. IM site 2 is the vastus lateralis. This muscle is located on the anterolateral aspect of the thigh. The nurse zeroes in on the body of this muscle by using the greater trochanter and the knee as landmarks. This site can tolerate up to 5 milliliters, but it is unusual to administer more than 3 milliliters with an IM injection. The last IM site is the ventral gluteal site, which involves the gluteus medius and minimus muscles. This is the preferred site according to current evidence-based practice guidelines because it is situated away from major nerves and blood vessels. The landmarks for this site include the greater trochanter, the anterior superior iliac spine, and the iliac crest. The ventral gluteal site can also tolerate up to 5 milliliters of medication. The dorsal gluteal is an old traditional site that's located on the buttocks. This site is no longer in favor and should not be used. Due to its proximity to the sciatic nerve, this site is associated with numerous nerve-related complications that occur when the sciatic nerve is inadvertently struck by the needle. On certain occasions, it may still be used, but it should not be used routinely. The Z-Track method is an IM injection technique that prevents leakage of the medication from the muscle into the subcutaneous tissue. It can be used for all IM injections, but it is most important to use this technique when giving an irritating or a painful medicine. The nurse pulls the tissue to one side at the injection site and does not release the tissue until the injection has been given and the needle withdrawn. In addition, patient permitting, the needle is left in place post-injection of the medication for a count of 10. This allows the medicine to disperse in the muscle, further limiting any leakage of the medication out of the muscle up to the sub-Q. This technique will be demonstrated in detail in each lab session. This concludes the presentation on IM injection.